بسم الله الرحمن الرحيم. يشرفني إني أبتدي the first session in مؤتمر سوهاج. Our session will be in uveitis. We will start with Professor Samir Shawky, diagnosis of ocular tuberculosis.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for the kind invitation. I'm really very happy to be here in this nice city of Sohag. I would like to welcome my professors and my colleagues from the Egyptian Uveitis Study Group. Today, I will talk about diagnosis of ocular TB. Tuberculosis is one of the top 10 causes of death in the world. About 1/3 of the general population are affected by TB. Imagine if we are 100 here, unfortunately, 30% have latent TB. The exact incidence of ocular TB is unknown, but it affects patients with uveitis in up to 10%. There is a very important piece of information here. More than 92% of patients with ocular TB have no concomitant pulmonary TB. Please keep this point in your mind. 92% of cases of ocular TB have no concomitant pulmonary TB. We have some problems in the diagnosis of ocular TB. The problems are, as we mentioned, most of the cases have no pulmonary TB, coexistent pulmonary TB. There are no specific diagnostic criteria for ocular TB. The other thing is the variable clinical manifestations. As we know, TB can cause any type of uveitis. It can cause granulomatous uveitis, non-granulomatous uveitis. And the most important is the absence of the general consensus for the diagnosis. But the gold standard, of course, for the diagnosis of ocular TB is the isolation of Mycobacterium tuberculosis from the ocular tissues. But this is very difficult in the eye because of two reasons. Because ocular TB is a paucibacillary disease. We have only few organisms in the anterior chamber. The second is the limited sample from the aqueous. Imagine how much you can obtain from the aqueous. Very minimal amount. So this makes the aqueous sampling very difficult and non-conclusive. So the diagnosis of ocular TB is usually presumptive. The important question now, if any one of you see this patient with anterior granulomatous uveitis and you have a positive quantiferon test, are you going to treat this patient based on this? This is a very important question. You have a patient with anterior granulomatous uveitis and a positive quantiferon test. What are the problems here? This could be due to TB, could be due to other cause, or could be due to both TB and something else. The problem also, the TB can cause disease by direct infection or by allergic reactions, and the treatment is different. So how would you proceed? Here comes the milestone study, which is the COTS study, the Collaborative Ocular Tuberculosis Study Group. And this group were put to address the knowledge gap in the diagnosis and the treatment of ocular TB. And it was a consensus which included 81 uveitis experts from the world, and I had the honor to be part of this prestigious group. And they put specific criteria to diagnose ocular TB. For example, if you have anterior uveitis, you must have a positive radiology. As you can see here, in all situations, you must have a positive CT chest or X-ray finding in addition to either positive tuberculin test or quantiferon in order to start treatment. So these are very tough criteria. Remember, you cannot start antitubercular medication without a chest X-ray or CT evidence according to the COTS criteria. In the case of intermediate uveitis, it is also the same. You must have a positive radiology in addition to either tuberculin or quantiferon TB test. For me, although I am a part of this study, these are very tough criteria. The only exception in the posterior uveitis is the serpiginous choroiditis, you can diagnose and treat based on either one of the immunological tests, even if you don't have chest X-ray finding. And this is the algorithm. But is this COTS study, despite its huge, applicable? In my opinion, it is not. The first, it is a consensus. It is not an evidence-based medicine, just a consensus. Because, as I mentioned, 60% of patients with extrapulmonary TB, they have no evidence of pulmonary TB. And 92% of patients with ocular TB have no evidence of chest infection. So why you insist on putting CT chest in the diagnostic criteria? Most of the patients don't have chest manifestations. So we use a simple criteria for the diagnosis of ocular TB, and this is what we used in clinical and in the research. The first is a compatible clinical finding. For example, as the patient we saw in the first with anterior granulomatous uveitis, for example, if you have a positive immunological test and you have a positive response, therapeutic response, and of course, exclusion of other causes of uveitis. Sorry. I will show you some of the cases that goes with the COTS and other cases that are not matching. This is a female patient with a classic anterior granulomatous uveitis with granuloma in the anterior chamber here. And all the tests were negative, as you can see here. But quantiferon was positive and the BBD was positive. And this is her CT chest, as you can see. This is the classic apical fibrosis and in the chest X-ray and the CT. So in this case, we don't have a problem. The diagnosis is clear. We have a positive quantiferon, positive TB, and positive CT chest. So it is a definite ocular TB. So there are no problems here in this patient. The other case, as you can see here, a male patient complained of pain in his left eye. As we can see here, the IOP was high and diffuse stellate KPs with 1+ cells and 1+ flare. I myself thought he had also arthritis. Based on the clinical presentation, unilateral affection, increased intraocular pressure, I thought of viral etiology at the start. Then I asked for the workup. Everything was normal, but he has positive quantiferon test and positive CT chest finding. So my diagnosis was ocular TB based on the COTS. So there are no problems here. The next case is a 42 female patient who complained of blurring of vision in both eyes. She had mild anterior uveitis, and you can see here, she had vitritis and this macular edema in both eyes, okay? So my diagnosis was anterior and the intermediate uveitis. I asked for the lab tests, all were normal. Apart from a very positive tuberculin test, 31 millimeter of induration, this is strongly positive. But her X-ray was non-conclusive. So if I follow the COTS, I will not treat this patient with anti-tubercular medication because she doesn't have X-ray findings, just the BBD. And the COTS, you must have a positive CT chest, but I didn't do this. I treated the patient with anti-tubercular medications alone, and this was after 40 days. There was no steroids. And you can see, this is the edema at the start, and this is after 40 days of anti-tubercular medications alone. And this is after 75 days, the macular edema completely subsided with anti-tubercular medications alone. So the last case, the 35 male patient, blurring of vision in both eyes. As we can see here, this is a picture of multifocal choroiditis in both eyes. This patient showed strongly positive BBD. You can see the scarring. There is very intense reaction, and the chest X-ray was normal. So if I apply the COTS criteria also, I will not treat this patient. Do you think this makes sense? If a patient has a very positive tuberculin like this, I will not treat, but we elected to treat the patient based on our criteria, and the patient dramatically improved. For the sake of time, I will skip this case. So, in conclusion, the COTS study, which is a collaborative ocular tuberculosis study, is a milestone. I am a part of this study. I encourage you and all my colleagues to apply the COTS But if you have a clinical sense that the patient has TB despite not having a positive CT chest or X-ray, please, your clinical judgment. And these are the list of our TB publications. And we are fortunate that just yesterday, our paper was published here. Alhamdulillah, سوهاج والشاي حلو علينا. Alhamdulillah, ربنا. Thank you. And this was our experience with Zoom TB. We are done. Thank you. So this